asking questions. But that being said, good afternoon. I am Sunil. I'm the Vice Chair of Research in the Department of Medicine and also co-director Center for Infectious Diseases in India at Johns Hopkins, along with Vidya. I've actually been involved with the HIV epidemic in India right from the beginning. So for many of you who don't know, Hopkins' affiliation with HIV in India goes right back to the identification of the first case. And I can tell you with utmost confidence, because my mom actually identified those cases, and they were not, there's nothing to talk about. But when they actually found those specimens, they actually came to Hopkins, and Tom Quinn's lab at Hopkins confirmed those specimens, and that was when they actually said, yes, we have HIV in India. But Hopkins has got a long way from there. Bob Bollinger has built careers of many Indian scientists. He's also run trials of many medications to evaluate mother-to-child transmission, which was extremely big in India, including showing that monogamous Indian housewives were the leading population affected by HIV in India. We transitioned from there to Shruti, Greg, and David building all these cohorts of people who inject drugs, men who have sex with men, really the populations on the fringes in India, and showing how you could actually deliver care in a very holistic way. All the way to when we had a PEPFAR award, we were actually partnering with the Indian government. We developed guidelines, India's first guidelines for PrEP that was in collaboration with Hopkins. So India has a very rich history in HIV with Hopkins. But I think as many of you are aware, it is all under threat right now. So I think the previous session also spoke about how PEPFAR is under threat. All the US aid awards, including our award, was terminated on February 26th this year, which has impacted over 175,000 people whom we are facilitating care for in India, including 8,000 children, where we were making sure they were in school and still getting their medications. And this was followed by a notice from the NIH this week about foreign subcontracts, which threatened many of our participants who are actively on trials receiving medications. So it's time for us to imagine or reimagine the global leadership in HIV and what is India's position and how do we actually take this forward. So to help me out, I actually have 4 experts whom I never thought I would actually be able to pull together so quickly in such a short time frame. So thank you very much for joining me. Chris, unfortunately, is joining us remotely, but he did join us despite some personal commitments. So I want to start with Dr. Monica Gandhi, who is a professor of medicine at UCSF. She's also the director of the CFAR at UCSF and has an extremely long history of developing novel therapeutics and really thinking outside the box. So in this current scenario, and she also leads the antiretroviral therapy group within the AIDS clinical trials group, which is the largest group looking at new therapeutics. So with all these changes happening globally, where do you see scientific progress? Because I think Dick ended the previous session by saying we can never stop. Innovation is critical. So how do you see this happening, and does India have any specific role to play?
Yeah, I mean, I thought that Dick's comments were prescient, that it'd be nice to change people's minds, but instead, actually, I think instead, we need to think about how to work within the current system, which is clearly disastrous, but I think that we can do some things. So one is that PEPFAR, which Chris will talk about, is actually still remaining a word in the administration. So USAID being gutted as a collaborating partner will not allow PEPFAR with its current funding levels to go forward, but in the budget that was proposed on May 6, 2025, that will now go to be evaluated by Congress, PEPFAR is still there, and the phrase is that PEPFAR will keep work with its current collaborating partners. So then it would be our goal to advocate as much as possible for PEPFAR to be in that budget and then obviously increase because to make up for the USAID cuts, which are devastating and terrible. So then in terms of the other thing that we can advocate for, the second is global research at the NIH, and that, though the stated position of the NIH leadership is that global health research should continue, and that is important. I think that there may have been not an understanding that changing things so fast will make which is announced on May 1st, there was a notice from the NIH that foreign subawards would not be allowed in parent grants. So we are let's say we're the domestic institution, and then we have in our grants, we have what are called subawards that we give, the money comes to us as the domestic institution, and then we give the money to Uganda or South Africa or India. And so that structure is going to be changed for the NIH, but in that structure, there is a path to change it, maybe more quickly than they're saying, but if we can keep the idea that has been stated that global health research is still important from the NIH, then again, what our goal is to advocate. And so not advocate, I think, by saying this is all terrible, which it is, because that doesn't help. I think it's within the current structure, who do we find to advocate with? Right now, PEPFAR is really the person who's responsible for PEPFAR in the State Department has changed. And there is a specific person with whom we can advocate, and the same with the NIH. There's a specific person, who's director with whom we can advocate. So I think we have to be as productive as possible within that current structure, because I agree that though, of course, we'll be appealing to Gates to help backfill PEPFAR once he's made this announcement. We need this public investment. There's just no doubt that this government needs to invest. And there's been a lot of chaos and misery, but maybe from that chaos and misery, we have to figure out what opportunities we have to bring back some of these programs.
Thank you, Monica. I just want to move to Professor Chris Beyrer, who's a professor of medicine and the director of the Duke Global Institute. But before that, he was at Hopkins. He was the inaugural Desmond Tutu Professor of Health and Human Rights. He also was the director of the Center for Health and Human Rights, and he was also the director of the Moupali AIDS Trip, which provided me with the education that I have. So wherever I'll be indebted to Chris. Chris also served as the past president of the International AIDS Society. So Chris has a lot of hats to wear, and Chris, I think Monica touched upon PEPFAR a little bit. And I think it is a challenging environment we're in, where PEPFAR to me is probably the single greatest thing that the US has ever done for the world, which is under threat now. But at the same time, there's also the whole DEI, where marginalized and sexual and gender minority populations are being impacted more than what they already were with PEPFAR. And India has a very long history of the trans community and trans people, which is probably older than the existence of the US. So I don't know if you want to share your opinions on where we think PEPFAR is heading and any role India potentially has.
Surely. Well, again, apologies for not being able to be with you there in person, but it seems that it's an exciting event, and as you noted, Sunil, long and I think very productive history between Hopkins and our Indian collaborators and partners, and certainly with the ATERP, with Bob Bollinger in the leadership for the India program for many years. We trained an awful lot of people over. We were part of the ATERP family for the entire period that the grant was active. That was 25 years. So 5 renewals until the NIH closed that down. I thought because of what Monica had said, it might be worth spending just a moment or two on really sort of clarifying what has happened with PEPFAR and why that's particularly important in a couple of critical areas. And the first thing to say, of course, is that PEPFAR itself is essentially a funding mechanism within the US government, created in 2003 by George W. Bush at the same time, same period that Kofi Annan led the creation of the Global Fund to fight AIDS, TB, and malaria, which both of these occurred in 2003. And essentially, PEPFAR is a bilateral between the US and its partner countries, and the Global Fund is a multilateral with UN and others. And we have been 33% of the Global Fund in the proposed budget that Monica mentioned. It's a reduction to 25%, but it still would be, it is substantial. And that's, of course, for AIDS, TB, and malaria, whereas PEPFAR was very much focused on HIV, AIDS, and related conditions. So the key thing to understand is that about 60% of all PEPFAR programming was implemented through USAID and then its contractors and government partners. So the dismantling of USAID, which is now all but complete, it is down from over 10,000 employees on the US government side to 15. And those 15 people are the positions are the ones that are congressionally mandated in the law, which created USAID in 1962 under the JFK administration. So those 15 people obviously can implement virtually nothing. And so USAID is functionally over. And since it implemented 60% of PEPFAR has not been able, despite the waivers and despite the efforts, to get back to anywhere near the level of functionality it was before the inauguration. The other 40% or so has been implemented through Health and Human Services, primarily through the CDC, and that was doing better. And after the sort of lifting Marco Rubio's waiver, we did start to see programming happening much more through the CDC, but unfortunately, the whole office that was managing the prevention of mother-to-child transmission component, was about 18 people in CDC, have all been fired, and that office is closed. So the technical support to even PMTCT is really threatened. But I think the other thing that's important to understand is that the last 2 years before 2025, so that's 2023 and 2024, were the best years ever for the implementation of pre-exposure prophylaxis. And we actually were starting to see real numbers and getting at least PrEP starts to scale in those 2 years. And 91% of all PrEP starts globally were supported by PEPFAR funded programs. So PEPFAR functionally was the implementation arm for PrEP, for biomedical prevention. And all of that has been stopped, and not put on pause, but actually put on a hold until further notice, with one exception. So PEPFAR is still providing PrEP for pregnant and lactating women who are at risk for HIV acquisition. But that's it. And so just as you alluded to with the key populations, Sunil, and our concerns about many of the communities, populations, individuals who would benefit the most from PrEP. So, for example, men who have sex with men, transgender women who have sex with men, women who sell or trade sex, and adolescents at risk. All of those populations, PrEP was stopped for, except, as I said, for pregnant and lactating women. Now, why is this a particular concern? It's a concern because there is of course, a desire on many people's parts, including many governments, to have a transition to country ownership. That has been a part of PEPFAR planning and programming and the Global Fund for a number of years. And many countries, India is a great example, have largely taken over running their own HIV testing and primary prevention programs and treatment programs and TB programs, of course, and they are very large in a number of countries. But where we've seen real problems is that country ownership can be a real challenge when countries don't want to invest and support these key populations. And in a number of countries, particularly where, for example, same-sex behavior is criminalized, or transgender cross-dressing is criminalized, trying to change one's gender, it's enormously difficult for these countries to implement prevention. Now, Sunil and Shruti are both leading experts in HIV among people who use drugs, people who inject drugs, substance users. These, again, in many, many parts of the world, are excluded from services, denied the basics, and at very high risk for HIV acquisition. Of course, we have some very fast-growing parts of the global epidemic, including in Eastern Europe and Central Asia, that have predominance of this risk factor and very little in the way of primary prevention services. So in that part of the world, HIV is still expanding. So I think this is an area where countries like India can really step up and lead and demonstrate what leadership looks like. Of course, homosexuality has been decriminalized in India. It is a different era. The transgender communities are longstanding a part of Indian culture from as far as we can tell from the earliest days. And here's an opportunity for country ownership, country leadership, and support for these programs. The treatment programs, of course, are already almost entirely India supported. And of course, India, is also a manufacturer and distributor of antivirals for both treatment and prevention in the generic sector. So I think there's a lot of the potential there. And of course, I know Moupali Das is here with us from Gilead. Gilead has done contracting for generic manufacture of its new drug, lenacapavir, with a number of Indian partners. So that too is, I think, extremely encouraging for the future. Many countries in the Asia Pacific could be doing a lot better for their populations and communities at risk. We would really love to see that in the Philippines and Thailand, Vietnam, Indonesia, a number of other countries that have really concentrated epidemics and that really do have the resources to address those epidemics domestically. I'll stop there.
Thank you, Chris. And next I want to turn to Dr. Shruti Mehta, who's actually been my partner in crime for HIV in India for almost 2 decades now. So she is a professor of epidemiology in the Charles Armstrong Chair. So for many of you who don't know, India has 2.4 million people living with HIV, which is the second largest in the world. But like Chris mentioned, the epidemic is concentrated in key populations such as men who have sex with men, people who inject drugs, and the trans community, which has been the focus of Shruti's work in India for almost 2 decades. Shruti, I guess the question for you is, we've built all this infrastructure over 2 years, we've provided all the training, and now everything seems to be in flux.
So I think that that Chris and Monica have done a nice job of kind of laying out the global challenges, and I'm going to take a little bit more of a personal bent to our program, just as an example, and I think that it's just one example of many. I'll say, as Sunil mentioned, I've been working in India for 25 years, first under the mentorship of Bob Bollinger, and then I had the privilege of working with Suniti Solomon, who identified those first cases, and then of course Sunil and our team, and I'll say it's one of the highlights of my career, not just for the impact that we've been able to have across India, but for the partnerships that we've made that have made all this possible. And where we came in India, we talked about key populations. The Indian government, has done amazing things in response to the HIV pandemic in terms of the response. The response was focused in the general population and on female sex workers who were the first identified as being affected by HIV, but there were groups that were being left behind, right? So gender and sexual minorities, people who inject drugs, and there were gaps in programming, and we essentially came in and tried to help fill those gaps. First by identifying what was the epidemiology of infection in these groups, what were the challenges, what were the barriers, and then by testing a series of different interventions to improve engagement in prevention and treatment services across India, really. And so you ask what is potentially lost and what could be lost. I think to understand that, it's sort of important to understand what we built. So I already mentioned partnership, right? None of this work happens with just us going in and doing work. It's partnership. It's partnership with NGOs on the ground. In particular for us, that was YRG Care, who has been our implementing partner for more than 20 years. Partnership with the government, right? So we have an idea, but we come in, we partner with the national, the state, the local, district government, both on the implementation of the idea and also some cost sharing, right, of some of the structural interventions that we've been implementing, and then partnership with other community partners and the communities themselves. So there's the partnership, there's the infrastructure that we've built. So our work goes around India. We've been in 27 cities across the country, and in each of those cities, we've built both physical infrastructure in terms of clinics that both deliver services and conduct research, and human infrastructure, right? We've trained a public health workforce that has been engaged in research and in many ways leading research now. And much of what you do as both a public health professional, but also as an educator, is you hope that you're building for the next generation of researchers, right? So this was infrastructure that was set up for HIV, but the idea is that people in India and the US build upon this infrastructure for both HIV as well as other infectious diseases and other chronic diseases. So I think these are all of the things that are at threat, right? So if we are stopped, full stop, then all of that investment, all of that infrastructure, we lose, this administration likes to talk about efficiency. This is like the opposite of efficiency because we're taking down what exists, and to build it back up is going to be incredibly challenging. So I think I agree with what everyone said. There is no one person that can fill the gap. We do need the public investment, but we have to think about where we can partner, and where is the other investment coming from? And I think India does have a unique position there. We talked about with HIV, India is a country that does supply its own medications, that's led the way with generics, that does have infrastructure. So how do we partner and add to the investment that comes from other places? Can we find ways for more investment in research? Can there be more investment for the wraparound services? So much of the work we do is to supplement the government programs that provide therapy, but don't necessarily recognize that just providing the service isn't enough. And people aren't going to use it just because it's there. You need the wraparound services. So again, how do we partner across all of the different potential sources of funds to continue this work? I think I'll just close by saying that, words of, again, one of my mentors who I've mentioned, Bob Bollinger, is that if you can do it in India, you can do it anywhere, right? And I think that is, leading by that example, and this idea that we're doing work in foreign settings, that it just benefits people in India. That is so not true, right? It's not. I've worked in India and Baltimore for decades, and the lessons I learned from one place are always applied in the other. And so I think that getting that message out and reminding people, it's not about one setting, one population, or global society, and what we learn in one place impacts another.
Thanks, Shruti. So I want you to imagine a time when no parent has to be worried that their daughter is going to acquire HIV as long as she's able to get two injections, one every 6 months, similar to your COVID vaccine. Right? That's something that was probably too far-fetched a couple of years ago, but lenacapavir in the Purpose 1 trials essentially showed us that all girls or women need to do is get one injection every 6 months, and the risk of HIV acquisition was zero. It was 100% efficacious. We have never seen anything like this, even with vaccines in the past. And I am extremely lucky to have Moupali here with us, who was actually part of the team who received the Science Breakthrough of the Year for their engagement with communities and stakeholders for Purpose 1, which was a study that showed lenacapavir could actually do this. Moupali is a vice president of clinical development, and she also heads the prevention program at Gilead Sciences. Moupali, Gilead has a very long-standing history of access, like right from Truvada, which was tenofovir and emtricitabine, all the way to your hepatitis C medications. So basically, it was Gilead's voluntary licensing for India that sort of saved most of the world through PEPFAR. So can you talk a little bit about what is the role of industry at this point in time, and Gilead's thoughts of where you think industry could fit in, given where we currently are in the world?
Yeah, thank you. First of all, apologies for not being there in person, but I couldn't tear myself away from the Mother's Day plans tomorrow that my boys had for me. But I would love to have been there with all of you. And thank you very much, Sunil, for inviting me to this panel. I think what we have to think about now is the entire ecosystem that it takes to take something that is a thought at the bench with a scientist funded by NIH through a rigorous, comprehensive development program, through getting that drug to whoever needs it the most, and prioritizing the people who have the most unmet need. And that takes an ecosystem of partnership with people playing key roles all along the way, and really intentional, thoughtful strategy to set up for what we can do to innovate and access. At Gilead, we are incredibly proud of our history of innovation in the science, bringing forth amazing products that have really helped impact the HIV epidemic, cure hepatitis C, treat severe fungal infections. People forget about ambisome and the importance of ambisome with black fungus in India during the COVID epidemic and visceral leishmaniasis, as well as our planning for lenacapavir. And so we were able to do all of this through our robust interaction with Indian generic manufacturers. And this started in 2003 when we established our own relationships between Gilead directly with voluntary licensees, they're called, or generic manufacturers. And we set up our own robust network at that time to help deliver tenofovir-based HIV treatments to the world. And that was in advance of the medicines patent pool, which is another mechanism for delivering generic medicines globally. And of course, we were the first pharmaceutical company to join the MPP and support the MPP. And many of our products are licensed through the MPP, which again forms partnerships with generic manufacturers, many in India. And we have done this we have worked with directly or through the MPP for HIV medications, hepatitis C medications, remdesivir during the COVID pandemic, ambisome, as I mentioned. And we have been planning very robustly to make sure that we can get lenacapavir to who needs it most. And specifically, we're working with 6 generic companies that we announced to cover 120 countries that are responsible for 70% of the burden of HIV globally. So we're working with Dr. Reddy's, MCure, and Hetero and Mylan in India, as well as Eva Pharma and Ferozens in Pakistan. I hope I'm saying that correctly. Eva Pharma in Egypt. And these generic manufacturers are not just simply making our medications, and we chose them because we've been working with them for many years to make these medications. But these generic pharmaceutical companies over the last 20 years have also innovated themselves, and they have thought of different ways to make the processes more efficient or better. So it's a really robust collaboration between the innovator sponsor and these generic manufacturers. And we need more of that to get to, high enough speed, high enough volume, figure out the best way to partner with all the different partners in the ecosystem. And I'm very proud of that history of the innovation that we've had in science, as well as figuring out pathways for access. And, on a personal note, my first experience working with HIV prevention was in India in 1996 and 1997, when I worked with Samrajit Jana, who was part of the Indian Hopkins India collaboration for in Kolkata, and he helped develop HIV prevention services for female sex workers in Kolkata and Sonagachi. And that was my first experience after college. Before I became a doctor doing HIV prevention work, I found out later, several years after I joined Gilead, that Dr. Jana's nonprofit had also been one of the PrEP demonstration projects that Gilead had supported and funded and provided product for after the approval of Truvada for PrEP. So this is a topic that I feel very passionate about from a personal perspective, as well as representing our company and the history of what we've done. This is an uncertain and challenging time. I won't be Pollyanna about that, but I have a lot of confidence in this decades-long collaboration that Gilead has had with Indian generic manufacturers, as well as innovators in access and policy in India and globally. And I hope that we can all come together to pick up the significant slack that has been left and try to make sure that lenacapavir for prevention gets to all the populations who need it the most. Thank you.
Thanks, Moupali. We'll open it up for questions, and while we are having people walk up to the mics for questions, Shruti or Monica, I think many times we look at international settings as resource-limited settings. But many times what we can actually do in these resource limited settings, we can't do in the US, which we consider resource rich. I don't know if you want to comment on that, or you have any thoughts on.
So, I mean, it's actually so much more cost effective to do research in India, for example, and then bring that here, that it seems easy to write foreign justification documents for the NIH to explain why research it can be done more efficiently and then more completely inform what's happening here, including dolutegravir resistance, which I and others are getting extremely worried about with antiretroviral interruptions. But the one thing I wanted to say is that the ACTG has a trial, and we're almost through the protocol. It's really going to happen, but we need some help with the hurdles of what's been happening recently of lenacapavir and cabotegravir as a dual injectable regimen in low and middle income countries. And specifically, it would be because, for a variety of reasons, but the other partner to cabotegravir is weak and it's just not being given out right. So anyway, really nicely, both the company that Moupali represents has agreed to the lenacapavir, this is for treatment, and then the other company that makes cabotegravir has agreed, and those two will be put together in low and middle income countries. And it will go through the ACTG and it'll be tested for an injectable regimen for treatment. And you can see how in India, if lenacapavir and cabotegravir are made by generics, those two really could be put together there readily. So we need to get over, we do need Gilead to please give the final commitment to the lenacapavir study. We're waiting to hear back from the World Times. And then we are already through the protocol actually, and then we need a hurdle that's been happening at the IH around the foreign sub-awards, which I actually think we can get through that hurdle. And if we get through that hurdle, we can launch this very quickly. And then I think that'll be really important for an injectable regimen for treatment, because the other one just hasn't, the other partner to cabotegravir is not good, is pretty weak and hasn't been made accessible.
Thanks, Monica. I think for those of you in the audience who are not familiar with lenacapavir or cabotegravir, they're both injectable medications. They just need to be taken once every 2 months or once every 6 months. And the trial that Monica is talking about is trying to see is, could you give people injections once every 2 months and not have to take any oral medications and achieve viral suppression, which is like HIV control. And this is of extreme relevance in settings like India, where we will have generic product and so could easily be operationalized at lower cost, but also for really vulnerable and populations where there's a lot of stigma of taking medications. Like a lot of people don't want to keep medications in their house because their brother will fail or their mother will fail. And then when you start working with populations who are experiencing homelessness or sleeping on the streets, a lot of them lose their medications. So that's going to be really huge if it actually works out for India. I don't know, Shruti, if you have any thoughts on other
resource-rich areas. Yeah, I think the biggest resource that India has is people. The human resource aspect of it. So one of the things that we think about in the ability to test interventions and the types of interventions we do is just that human power. I think I mentioned in the key populations that we work with, one of the challenges is not actually the availability of medications. It's about getting people to the appointment to take those medications, providing the support that's necessary. So I think one is just remembering that people power. The other piece is just I mentioned at the outset that I work in both Baltimore and India. And, one of the spaces that we've worked in together is in structural interventions, recognizing that you can't focus just on individual level behavior, but in some ways we have to change the systems through which we deliver treatment and services. And I found that willingness to think outside the box, to allow for us to test different models of care has been, something that we've been able to do in India. I don't know if that's a resource-rich or a resource-challenged issue, but I just think that willingness to push the system a little bit is something that we've been able to do.
Thank you very much, Sunil, and thank you for a really interesting panel. I had a question about advocacy. Several of you have talked about advocacy, and I think that there are at least two different. Is Michael, can you hear me? I don't think it's on. Maybe I need to switch on. Okay, sorry. Let me try again. I had a question about advocacy, and I think there's at least two different dimensions to advocacy that the panel has talked about. One is around advocating with the US government, the US administration around investment in science, investment in partnerships and development assistance. And the other one is perhaps more around marginalized populations and how to make sure that they really have access to healthcare services. I have a sense that sitting in a US university, we are not in a good position right now to be taking messages to the US administration about either of these. But I do wonder whether the panel has reflections as to whether there is a role for the Indian government or for stakeholders in India, but also certainly for corporations and for affected communities. Just briefly, reflecting back on what happened in the early years of HIV/AIDS, where I think the gay community had so much impact in terms of how HIV was approached and thought about in development assistance programs. Is there anything that we can take away from that to help inform what's currently going on? Thank you.
I know we have several advocates on this group, but I will turn to Chris, who's probably the advocate of all advocates.
Well, thank you. I think that was Sarah Bennett, wasn't it?
Yes.
Hi, Sarah. Good to hear your voice. I think one area, just as an example, in terms of advocacy with the U.S. government, is that I was reflecting back in recent conversations around the Fogarty International Center. I'm on the council for Fogarty now, so playing a different role. But in the first Trump administration, some folks will remember that the Fogarty was zeroed out in the president's first year budget to be eliminated entirely. And Bob Bollinger actually was one of the people, myself, Carlos Del Rio at Emory, several others, who really formed a small team and really started to try and advocate and protect the Fogarty International Center. And one of the things that led to was many of us really didn't know much about Congressman Fogarty, who it was named for, who turned out to have been a Rhode Island Democrat who was a labor unionist and was really interested in workers' health, and got interested in global health because he'd seen the terrible conditions that many factory workers and miners and others were living in LMIC. But he had a surviving daughter who wanted to keep her father's legacy alive. And, we got her down to the Congress, and she talked about her father and his legacy and why this mattered. And she was a really effective spokesperson, and I think really moved a lot of the particularly younger Congress people who'd never heard of John Fogarty and hadn't served with him. So once again, the Fogarty is zeroed out in the president's budget to be eliminated. It's probably because it has that dangerous middle word, international, in it. And it always seems to be a target. But for those of you who know, and Sunil Solomon is a great example of somebody who has, was a recipient of Fogarty funding for his PhD. This is a program that has trained just really generations of people in leadership now. In HIV/AIDS globally, and it has been so important, and it would continue to be important. This is going to be another advocacy fight, and I think we're going to have some of those same skillful kinds of means approaches. We actually, we have a very specific target audience, and that is we need 3 or 4 Republican senators to move in support of the NIH and in support of this international mission. It's not that many people. It's a heavy lift, but it's not that many people. And so it's a relatively targeted audience that we have to get in front of and get these messages to. Sometimes it seems that, you're re-advocating battles you think you've already won, but here we are, and we still have to do it.
Sarah, just to add about the community advocacy side of things, so you're aware that when our USA program was terminated, all our clinics for the trans community, the Mitzvah clinics, were shut down. On the Hopkins side, we weren't really allowed to talk because we wanted to keep everything under the radar. But the trans community in India started going to the press. Right? So we were covered on BBC, we were covered on the Deccan Herald and multiple news channels. And what resulted from that was the Tata Trust got in touch with us, the Tata Foundations, and said, this is something we would like to support if there's an opportunity. So we actually submitted a proposal to the Tata Trust. We're actually restarting those clinics now with funding from Tata's. So I think, well, nothing to do. Sorry, just to say that we'll move to the question.
Yeah, so thanks for the panel. So my question is, about actually AIDS. We do a lot of work on HIV, yes, for sure, yes. But why hasn't there been, more research done on AIDS, as you know, in the AIDS altar? Because I believe on philosophy, no person left behind, which we all say, right? Why is it somebody who develops HIV then obviously has AIDS? Why isn't there something done for them as well? Can you please throw perspective on it?
Actually, I think that's such a good question because the Clinton Health Access Foundation did an analysis of the impacts of our stoppages because of the USAID need collaboration, and it was AIDS that got the most affected because there's so many in low and middle income countries, people present often with late stage HIV because of stigma and other things, and actually you need then quickly fluconazole for cryptococcal meningitis, or you need methadone sulfate for PJP. So the people who are with the PEPFAR impact tracker model is showing that there's been 45,000 adults and 4,785 children as of yesterday who are of HIV since January 24th, when the work stopper was put in. It's because of AIDS. It's because of AIDS. It's because of late stage AIDS, and then you get sick. So I don't think people, and Moupali mentioned about Amazon, but I don't know if we knew how much opportunistic infections also were supported. The treatment of those were supported by.
Yeah, a lot of times, like nobody even cares about symptoms. You could be poor and like, oh, I just have flu or something.
Yeah.
And it just develops AIDS.
So it's a really good point to win the advocacy to talk about how easy it is. Fluconazole is very cheap. Like how we need also the support for the complications of HIV when your T cells go down too low, and that's a really, really important point in our advocacy.
Thanks. Any last questions for anyone? Locally, I guess a question for you is, what next? We have one injection every 6 months with 100% efficacy. Like, are we looking at 1 year, 2 years? Is it going to become a vaccine?
Yeah, so we don't stop. People who know our history know that we were the first to make a combination pill or a single tablet regimen with 3 different medications, and we kept iterating and improving. So every new version of a new combination tablet outperformed the prior version in gains in either efficacy or safety and tolerability. And we're continuing to innovate. So Sunil is referring to data that we shared at the most recent HIV conference at CROI in San Francisco, where we showed that we have formulations of lenacapavir, a different formulation than the subcutaneous injection that we've just been discussing so far, that can last beyond a year. So we are moving forward in evaluating those annual formulations. And for HIV treatment, we know that there are a lot of people who have challenges taking daily medications, but do not like injections. And we are continuing to innovate along with other sponsors and other partners to try to get longer acting oral medications, something someone could take once a week, maybe coinciding with a methadone clinic visit, or maybe once a month even. So we're looking at those formulations for treatment, and we're hopeful. Obviously, usually things, if they work for treatment, end up working for HIV prevention. So if we can get a longer acting oral pill, that could also really help expand the population of people who are benefiting from HIV prevention and treatment methods. So we are continuing to look at that and working really hard to start the annual formulation trial this year, in a couple months, actually.
Thank you, Mehta. end by thanking all the four panelists for being here. I think all of you in the audience recognize that this is probably the most exciting time for HIV than we have seen any time from the discovery of heart, probably. And since heart is probably with a long-acting formulation and the ability to actually eliminate HIV, has we've never been closer. And at the same time, we're in an environment where funding is threatened. But like Monica said and Chris said, there's no point in saying, oh, we can't do this. I think we need to figure out how we actually do this within the existing environment and within the existing structure of the government and what they want to fund. And I think my policy has always been if one door closes, you either push that door really hard to make right open or just find another door. And I think there are multiple other doors which we haven't looked at. And so like many of you know that Gates just pledged almost the entire fortune, but there are many more Gates in India. Right, who are probably have larger fortunes which we don't know about. So the question is like, how do we break those walls open and find all those fortunes? So thank you again for coming, and thank you to all my panelists for joining us here today. Thank you.
Take care, everybody.
Thank you.
Thanks. Happy Mother's Day, Moupali.
Oh, thank you. Happy Mother's Day to all the mothers.
Indeed.
Madam. Thank you, smile.
Got it.
Thank you.
Thank you so much.
You always smile.
Smile.
Doing the picture.
We're going to take a short 2-minute break, and then we'll be back with our country level director, Natisha Bezra.
Grab a picture of the three of
You want to go?
There's fine.
Closer.
Oh, okay, thank you.
It's a USAID funded project.
Thank you.
Just the addition.
Yeah. So we've gone through kind of the springer. We were, the stuff